Okay, well, welcome everyone to day two of the 2024 Public Health Learning Forum. We are so excited about our first session of the day, Culture Catalysts, Transforming Tribal Public Health Through Core Values and Staff Development. Before we jump in, we just have a few housekeeping items to go over. Audio is available on your computer or by phone. We kindly ask that you please keep yourself on mute to avoid any background noise, but we do encourage you to have your cameras on so we can see your faces throughout the session. We want you to be as involved as possible, so please feel free to drop your questions into the chat box, and we'll do our best to respond as we go. There will be time for Q&A with the presenter following this presentation. If you have any technical questions, please send a message in the chat to Nolan Gill or Brittany Rector, who will be our tech support for this session. Thank you, Nolan and Brittany, for taking care of all of our technology issues. All sessions are being recorded and will be available on the Train Learning Network in the coming weeks. Once the recordings are live, all registered participants will receive an email with the details. We are so honored to hear from Dr. Mona Zuffante. Dr. Zuffante is a proud member of the Seneca Cayuga Nation of Oklahoma and the Chief Public Health Director for the Winnebago Public Health Department. With a background in environmental health and a PhD in Indigenous health, Dr. Zuffante has successfully managed numerous grants and projects, contributing significantly to public health initiatives. Outside of her professional achievements, she is a dedicated mother of 4 and enjoys beading, sewing, and gardening. The full version of her bio is available in the resources section of the conference page on Train. By the end of this 90-minute session, you should be able to explain how the Winnebago Public Health Department staff came to understand and contribute to strategies aimed at improving workforce retention and organizational performance. Describe how the Winnebago Public Health Department staff are able to articulate the organization's core values and describe how these values are embedded in daily operations, and describe how the Winnebago Public Health Department staff implemented the quality improvement and performance management strategies to enhance organizational efficiency. So as you listen to this presentation, we'd like you to think about ways to engage your staff in the workforce development planning process. Consider how you could be prepared to adapt and embrace challenges, as the most impactful changes often come from those experiences. So I will now go ahead and turn it over to Dr. Zuffante.
All right. So I am on the West Coast this morning, so I'm not quite in Winnebago. So I would like to greet everyone. So Heini P, Hini Kadagi, Lena, Ho-Chang, Rajada, Hua, Exxon, Huna, Sana, Makade, Mona Zafantega, Wauna Shana. So good morning, everybody. Welcome. My name is Mona Zuffante. I come here today to bring cultural catalysts transforming tribal public health through core values and staff development. And so I'd like to start with the land acknowledgement. And since I am not here in Winnebago, it will be for the Pacific Northwest region and recognizes the Indigenous people who have historically lived and stewarded these lands for thousands of years. So I acknowledge that we are on the traditional, ancestral, and unceded territory of the Coast Salish people, including the Duwamish, the Squamish, the Tulapi, and the Muckleshoot tribes. We honor their enduring connection to this land, the water, and culture, and we pay our respects to their elders, past, present, and emerging. And so we can go to the next slide. And so today's agenda, I'm going to go through the Ho-Chunk history, staff input, influences on workforce retention, our organizational performance, core values embedded into our daily operations, improving morale, implementing the quality improvement and performance management strategies, higher quality of services and better performance metrics, and some next steps. Next. So this is supposed to say, so you have to get into Mentimeter. How many of you work with tribal nations? And so it just says yes, no, or you're not sure if you do. So we'll give that a few minutes, or not really a few minutes, maybe a minute. I got a lot of slides, so. So it looks like there's the question again, sorry, is whether you work with tribal nations in your role or in your department. All right, so it looks like kind of half of you do, half of you don't. Oh, and not sure, and I'm not sure what happened to the screen. Okay.
It seemed like some people couldn't see the slides, so I stopped sharing and reshared. So I hope that solves the problem.
All right, so we could go ahead and go to the next slide. All right, so so the Winnebago are a woodland tribe that speak a Siouan dialect. They were hunters, gatherers, and fishermen. The ancestral lands are in Wisconsin and northern Illinois. The Winnebago people called them the Ho-Chunk people, which means people of the parent speech or the big voice. And then you can see that the English name is Winnebago is derived from an Algonquin form of Winnebago, which means people of the dirty water, which is based off of Fox River, because every summer it becomes clogged with rotting bodies of dead fish, or certain parts of the year become overgrown with algae. So next. So our sister tribes before 1600, the Missourians, the Iowas, and the Otos broke off from the main body of the Winnebagos and migrated westward. The left Winnebago people on Lake Michigan by Green Bay, Wisconsin. And before this split, the tribe was so large that each clan had its own chief. Single civil chief presided over the entire tribe. So next slide. So this shows the removal of the Ho-Chunk people, and they were displaced for 5 major removals. And so you can see through the map here is that they started in Wisconsin, and then they went up to Minnesota, and then over to Crow Creek, and then or to Blue Earth, and then Crow Creek, and then now in Winnebago Reservation, where we currently reside. So next. So the Treaty of 1865, the U.S. government purchased the northern tract of the Omaha Indian Reservation, which established the Winnebago Reservation. Some of the tribal leaders and villages refused to leave or made their way back to their ancestral lands in Wisconsin, and this is why we have Ho-Chunks in Wisconsin, which became a permanent split between the tribes, which is why we have the Winnebago tribe in Nebraska, and then the Ho-Chunk Nation of Wisconsin. So next slide. And I always like to start with history because it allows you to kind of understand as we move forward with our how our department functions, that history really plays a lot to do with that. And so the Winnebago tribe in Nebraska has a total enrollment of 5,306 individuals, and 2,700 roughly live on Winnebago or the surrounding areas. Next slide. So our governing body for the tribe is ran by the tribal council, which is a 9-member elected by the tribal members. 9 members then vote for 4 internal elected positions on the council, and that is our chairman, vice chair, and secretary and treasurer. And so every year we have 3 members that are re-elected or elected to serve on the tribal council. So next. So just to give an idea about self-governance, the tribal self-governance is the framework that empowers tribes to assume administration of programs performed by the federal government and prioritize their needs and plans, their futures at their own pace, consistent with their own distinct cultural traditions and institutions. The Winnebago tribe started their self-governance planning process in 2015 to assume the operation of the federally operated hospital on the reservation. And the Winnebago Public Health Department was included in this process. So next slide. So the health department actually started back in the 1970s under the Indian Self-Determination Act, which allowed for self-governance. Sorry, I like to use my hands. And so back in the 1970s, we started with 2 CHRs and 1 PHN, and we had expanded throughout the years, contracting and now compacting. Next slide. So on July 1st, 2018, through that same self-governance process, the Winnebago tribe assumed control of its healthcare system. The Winnebago Comprehensive Healthcare System was created as a separate entity comprised of the Winnebago Public Health Department and the now 12 Clans Unity Hospital. This entity is still under the tribe, but has its own board of directors that govern it. Next slide. So, oops, sorry, I jumped ahead. So WCHS has 2 sides, or as I like to call them, sisters. We have the Winnebago Public Health Department and then the 12 Clans Unity Hospital. Next slide. So the Winnebago Public Health Department is actually located, the majority of our services, within the 12 Clans Unity Hospital. And we have both continued to evolve since the tribe assumed about 6 years ago. And we are going through a master facility change. So we may look a little bit different here in the next few years. So it's very exciting because that means that we have a lot of growth and expanding. So we've outgrown our space. Next. So as I talked about the structure, and this plays important as we move through here, the board of directors currently is 5 members. We are going to be expanding that. 2 members are directly from the tribal council. Another member is from an academic resource. Another one is a longstanding community member. And then we have a tribal community member. And then we have our Chief Executive Officer, David Edwards, which oversees the entire Winnebago Comprehensive Healthcare System. And then you have me as the Chief Public Health Officer. And I have 18 field public health directors. So next. And we'll go over those here in a short minute. So as many of you probably went through some strategic planning, we developed our vision statement, and we'll talk a little bit more about it, but we strive to create and maintain a healthy community. We proudly and proactively serve the evolving needs of our community. We really want our staff members to take pride in their work, model healthy behaviors, provide culturally centered, appropriate services, and also have excellent internal and external customer service. Next. So we went round and round and round about how do we achieve our mission. And so basically we landed on the 10 essential public health services, with equity, of course, being in the middle. Next. So what are some of the core values that your organization has set? So that's another Mentimeter, so you can get in there. And the code, you can join it here at the top, and then the code, you just punch that in to participate. And I think they have it in the chat as well. Grit, I love that. That encompasses so much. I love seeing that. Integrity, equity, service, respect. That seems inclusion. And equity just keeps coming to the surface. So So amazing. So we can go to the next one. We have a lot to get through. Okay, so we landed on our core values as respect, having a high regard for feelings, wishes, rights, or traditions of others. We really wanted to make sure our staff understood cultural sensitivity, being aware of cultural differences and similarities between our people exist without assigning them a value, positive or negative, better or worse, right or wrong. We are also in a very small community, so making sure that confidentiality is very important, so keeping of another person's or entity's information private. And then, of course, professionalism. So making sure our staff was having good judgment, being polite, because again, we live in a small community. Many people are related to one another. So we just wanted to make sure that those values were demonstrated throughout our staff. So next. So as we develop our um, initiatives going forward, we always remember the Indigenous social determinants of health framework. And so this emerging framework is really the connectedness and responsibility to each other, to our ancestors, and to the animate and inanimate beings around us, the reflection of a balanced relationship among our body, mind, and spirit in the context. And so you can see through the slide or on this slide that we take into consideration tribal sovereignty and governance in that determinants, the community's health and well-being, language and identity for our people, that Indigenous knowledge, and then, of course, our relationship to the land and kinship as well. And you can see that at the 7 generations if you want to Google more. So next slide. So we also think about it as another framework as we're looking through the hierarchy of individual, interpersonal, organizational, community, and public policy. Many of you, I'm bad at right and left, so I think that might be on your right. But also when we look to the other side, we really want to make sure that we're also considering creator, nature, place, our culture, our ancestors, those future generations, our elders, and everyone else that makes up all of those spheres around the individual. And so as we do our programming and our activities, we really try to take into consideration all of those areas as we move forward. So next slide. So how many staff are within your organization? So the total amount. So you should be able to put one in. Wow, 1,300. 250, 30s. So a gamut of from very large organizations to some, I think, as small as 10. And we have 70, I see, and kind of all in between. So so thank you for, oh, we even have 5. So some very, very small and some very, very big organizations out there today. So the next slide. So this is the Winnebago Public Health Department, our org chart. And so I'll kind of go through um, each of these departments and kind of go over their functions because it really leads to the vast of the health department and how we function all together. So our very first program is on the next page. So our domestic violence program, we do operate a 30-day on-site housing. We assist with basic needs, assist with safety plans, referrals to other programs. And so they reside under our behavioral health wing. Next one. Our medical services program. So we really try to take the access of care issues that many people experience when trying to access medical needs out of the question. Of course, there's always someone that needs transportation and forgets about our program, but we really try. So under that program is our EMS, so our emergency medical services, and what you think they do, they do. They wait for people, unfortunately, to be sick, and then they bring them from their homes to our 12 Clans Unity Hospital, or they'll transfer from the 12 Clans Unity Hospital to outside hospitals. And they can go far and wide. They can, so if you're not familiar with Nebraska, we're in the northeast section, and our nearest trauma level 1 hospital is about 75 miles away in Omaha. And our trauma level 2 is only in Sioux City, which is about 20 miles away. So it really depends on what the need of the individual is. Our CHR program, community health representatives, is really close to what I think you might be familiar with CHWs. And so our CHRs have been around since the 1970s. And so they can do blood pressures, glucose screenings. They do our lifeline. They do first aid. And they also do transportation from patients' home to the 12 Clans Unity Hospital. So people that don't necessarily need to be transported by the ambulance, but maybe become sick at home and just need a ride to the hospital, that they can do that for them. Or if they have an appointment, they can also do that for them. We also transport from our facility to other facilities, and that's under our transportation program. Also, if people are transferred from our ER at the 12 Clans Unity Hospital, our transportation program, because you usually, if you go by ambulance, do not take your car, right? And so now you're stuck at a different location. You can call this program, and no matter what time of day, someone will go pick you up from whatever hospital you went to, and bring you back to our facility or to home, depending on where you live. We also provide a shuttle service between our 12 Clans Unity Hospital and the urban Native Center connections up in Sioux City. We also do labs to other areas. So many things there. So it's very exciting. So we really try to take that access to care issue out of the way. Our next program, next, is our public health nursing. And so they do a lot of case management of chronic disease. They do elder care. We have a very robust prenatal postpartum program. They really work in conjunction with the hospital side. We provide immunizations. They're getting ready for their big flu vaccines. They even administer to our non-Native relatives, because we primarily focus on our Native relatives within our community. But they also do that outside. They go to the casino, which is across the river, and provide that. We do school health programs and a bunch of variety of things. So basically, if someone gets discharged from the hospital, one of our PHNs usually are tasked with going and checking on them, making sure they have all their meds ready to go. If they have any information that they don't understand, especially medical, then our PHNs can help them through that. So next. Our WIG program is probably what you are very familiar with, women's, infants, and children. Of course, they have little cards now that they can go to participating retailers and get cereal, formula. We also do a lot of breastfeeding support in both the PHNs as well as the WIC program, getting lactation services for them, pumps, and all of that good stuff, checking on the children as they're growing, making sure they have an opportunity to get fresh fruits and vegetables, and of course, cereals and other things. So very grateful for that program. So next. Our senior citizens program. Now, remember, we have roughly about 2,400 people in our community, and we serve about 127, 28 meals every single day. We provide lunch for the seniors Monday through Friday. A senior in Winnebago is 55. So if anyone were looked at data, you can see that the life expectancy of nationally for American Indian Alaska Natives are only about 58. Which was greatly reduced during COVID. And so, so unfortunately, we have lots of work to do there to increase that to be more in line with other races, but we're getting there. So Meals on Wheels, we provide that to those that are in medical need. So we'll bring that to their houses. We also do transportation when they get their first of the month check. We take them to Sioux City to be able to get groceries or whatever they may need. We also have legal assistants come into the program. So if they need to do a will or whatever they want to do in that realm, they can do that there. And then we have home chore assistants as well. So if they have like laundry or light things that they need done, then that person can help them too. Next.
Mona, if you don't mind,
Yep.
this is Ron. Can I just chime in with a question
Yes,
that came in through the chat?
of course.
The question was, do the healthcare facilities and the other facilities know about the transportation services, and how do you spread the word?
So yes and no. So we definitely, if the ambulance takes someone to another facility, we make sure that that patient or that relative knows that, hey, when you get discharged, make sure you call back to the hospital because we can have someone come and get you. And then we usually let the ER staff know too, because sometimes they'll ask like, how are they getting home? And then we'll say, hey, call this number, call back to the hospital, and they can send someone after them. So we just try to continue to educate people. I know our EMS staff does that a lot. The MVO staff does that as well. And I'm sure that the 12 Clans does that as well. And of course, we have a very robust Facebook page. So we try to educate our relatives everywhere on what's going on, the new things that are going on, the new services that we may have. And so everybody seems to be on Facebook, so which is good.
Well, thank you so much. And Mona, if I interrupt with other questions and it becomes too much, please say, Ron, hold. Thank
No
you.
problem.
It's always
I like
great
answering.
it's great having an engaged group of people that ask questions too. And
Yes,
sharing their
absolutely.
own thinking. Thank you.
Yes. So we also have several clinical services under our umbrella. So our YEP NAGU is our, it says diabetes because they're formerly our diabetes program, but really they do a lot more than just diabetes. They really do a lot of chronic care management, but their main focus is on our diabetic population. They provide education not only to the community, but also to the providers on the 12 Clans Unity Hospital side. We do freezer meal workshops for the community. They do community screenings. They have well, now they almost have 3 classes. So we have our diabetes prevention class, our Ho Chunk Hope, and then our diabetes self-management education and support classes. And then we'll learn here very shortly about one of their quality improvement under the T-CHIP, or our Tribal Community Health Improvement Plan, that you'll hear about in just a few minutes down the way. And so, because that's very exciting, so I don't want to take away from that. We also have our dental program that they do basic, of course, dental care, but we also do orthodontics. So we're one of the few tribal programs that do that. We do braces for 18 and below, and then Invisalign for 16 and above. We do cosmetic dentistry, pediatric dentistry. We do a lot of fluoride treatments. We bring in sealant clinics, so we bring all the kids into the clinic at least once or twice a year if we can get them all in to put sealants on. And so it's very exciting, and we're starting to look at some master planning, so expanding some of our chairs. So it's much needed, and everybody loves the dental clinic, if you can believe it. Next slide. Another one of our services is optometry. And so we do what you think optometry does. We do have a machine that we don't always have to dilate everybody's eyes now, but we always still do that with our diabetics. We really work very closely with our YEP NAGU program. And we also do glasses and contacts for cost. Next. And a couple of our other ones, we have our behavioral health program. So they do a lot of the therapy. We have 3 therapists on staff right now. And they do screenings and intakes and assessments and case management. And we have 2 psychiatrists that come on board 3 days a week. So that's very exciting to be able to do the med management. And of course, they work very closely with our recovery program, which we do have a 10-bed halfway house. We have 5 men and 5 women that we can house there. They also do groups. They have an outpatient facility on the bottom, on the lower level. And so they do a treatment planning, screenings, assessments, intakes, and then, of course, referrals to other treatment facilities. Next. So our health promotions and education do exactly what you think they should do. They get into the schools. We have our Project Woshkapi that teaches the Botman life skills to 5th through 8th grade. And so they instill self-esteem and pride. And then we have our more traditional outside of the community education with health fairs and meth and suicide awareness. We do a lot of health fairs and a lot of t-shirt giveaways. But everybody loves those t-shirts. And but it's a good marketing way to get people in. Talking about like, for instance, it is breast cancer awareness, and so they'll be doing walks and mini health fairs, and so just really trying to engage with the community on there. Our next program, environmental health. We do lead and well inspections. She does all of the home and food inspections of all the establishments, as well as the facility inspections. We do a pet care clinic. We partner with, which is on the slide, a neighboring vet that comes in and provides vaccinations and heartworm and all kinds of things for our fur relatives. And then outside that, our environmental health specialist, she does provide vaccinations throughout the year after that. We also have a spay and neuter program because we want to make sure that we try to curb as much as we can the population. And then that also keeps bites down as well as strays. And so we really try to work on that. Of course, vector control. Fall prevention. They collect ticks in the summer. In fact, they're finishing that up, I think, today, and then start mosquito collecting and all kinds of interesting, exciting things in environmental health world. Our next one is our Urban Indian Connections. And so this is actually based out of Sioux City, which is about 20 miles north of us. So this program really works with our Indigenous relatives in the urban setting. They work with advocacy, transportation, cultural activities. They have a youth group that they work with. They're really trying to encourage our Indigenous youth to complete high school and really working with them, doing after-school programming, homework, and all kinds of good stuff. So they've really been able to increase that or decrease the dropout rate. Urban Indian Connections is located on 5th Street in Sioux City, if you're familiar with that. And so they are usually at least have one member there. And that's where the shuttle also is located. Our next program, our Woja Kina Waka Ra Sisiski is our home visiting program. So it is our maternal child health program. We're very excited because that's brand new. So they just did their needs assessment. They're forming a coalition, and it's really data driven and making sure that we're going to select the right home visiting program for our maternal child health that really resonates with our people. So we're very excited. We're in our just starting our 2nd year of this program. So I'm very excited. I hope everybody else is too. Our next program is our mobile community crisis response. And so we're really looking at how does this response look like in our community? So they also developed a coalition. They have a case manager, and it's really trying to get services right to the individuals within the community. So if you're in a crisis, a behavioral health crisis, then our team can go and visit with you. And it's really trying to alleviate our relatives from going to jail or to the ER if not necessary. But of course, if that is necessary, then our staff will assist with hopefully not going to jail, but going to the emergency room if they're needing inpatient treatment for their crisis at that time. But so this is brand new. We just started launching it actually this month. So we're very excited to be able to provide this to our relatives. This was one of the things that we identified in our tribal community health improvement plan, is that the need for behavioral health crisis intervention, so that our people wouldn't have to necessarily go far away if we can stabilize them. And so the nearest behavioral health inpatient is about 2 hours away. Um, and so, and if they don't get in there, the other one is about 6 hours away, and there's like one more in between. And so really our relatives are being sent pretty far away. And so that's not really conducive for getting the services that they need and back into the community. So next one. We're almost done with my programs. Our Wajoki program is a revitalization of kinship support around pregnant, capable people. This is also one of our newest programs again. And so it's really in conjunction with our Wojokina program. And so it's really looking at incorporating culturally appropriate doula care, and as well as kinship support around that, and instilling birthing ceremonies. And so we're very excited about what that would look like. Our coalition has been formed and moving forward on that. So it's very, very exciting and community driven. And so that's the most important pieces to us. And my final program for this year is our Whirling Thunder Wellness Program. And so they do a lot of our wellness, fitness. They have adult health promotion programs. We have activities for our adults at noon and 5 o'clock pretty much every single day. They have different things on their calendar. They have youth sports. They have softball leagues for the adults, and fast pitch and softball, or fast pitch softball and baseball. There we go. And then all kinds of other things. They work very closely with our YEP NAGU program with those individuals, and really focus on our target population is K through second that have an elevated BMI or have an elevated A1C. And so we're really trying to target and getting those interventions to our youth sooner than later, so we can hopefully make some lifestyle changes before it's a little bit harder as they get older to do. So next. So thinking about all those programs that we have, our community priorities and visions are really to promote and provide support to our community members, incorporate our cultural practices and knowledges. We provide more education, have more available supplies, group classes, and those are really the priorities and visions of our community. Next. And we identified that we have a lot of protective factors within our community. We have a hospital and the health department that are located within the community. And actually, most of us are all in the same building. That really helps be like a one-stop shop for our people. We have a lot of relationship building. We have culturally appropriate, culturally based programs. We have programs that identify with cultural awareness. We really want to be a cultural safe care. We encompass and have inclusion of the local protocols. We include elders in our programming as well as youth whenever we can. Next. So the strengths of our community, we have a lot of community engagement, collaboration. The health department is about 80% Indigenous staff. And we consider that in all of our operations. Leadership and management really try to support their workers and have a collaborative approach. I always think that if we have happy workers, then we'll have happy clients, because the people are happy and engaging with our relatives that are coming in. We promote education within our department. We have many that have started off just with their high school diploma, and now some of them have their bachelor's and are working on their master's, and it's just very It's very exciting to see all of the growth within our department. We're very community centered. We have a lot of events and activities throughout the community. And really, when we look back, the health department is really the backbone of the community. We really support all the other entities and many things that they do. But on the next slide, we do have our challenges. So we still want to connect with our Ho-Chunk identity, gathering and document and disseminating cultural information. Our births are not within our community. Most of our female relatives deliver in Sioux City, which is 20 miles away, or in other areas, depending on their needs and wants. We still have a lot of historical trauma as well as mistrust of our healthcare system. Next. So what is public health? And as we all know, it's defined as the science and art of preventing disease, right? And we can see all of those people go into supporting the public health agency. And so I always like the story of the three sisters, and some of you probably have already heard that, but, and I'm a storyteller too, if you haven't found out by now. But so we're three sisters walking along a river. And the three sisters are walking and they see these babies coming down the river. And the first sister runs over there and she starts grabbing those babies and putting them up on the bank. And she starts yelling at her other sisters. And the other sister says, "Hey, we should teach those babies how to swim." And the other sister is starting to run up the stream. And the sisters say, "Hey, what are you doing? Come back here and help us." And she's like, "No, I'm going upstream and I'm going to find who's putting those babies in the water and I'm going to stop them." And so it's right along with like Jon Snow, right? Removing the handle is that public health is really upstream, right? So we are trying to prevent everything from going downstream, like to the hospital. And so I always think of how important we all are as public health entities, is that we're really trying to make effective change for our people. So next. So can you think of other stories that demonstrate the example or importance of public health in your own? And you don't have to share them. You could just say yes and no and maybe. They told me to be engaging, so I'm trying to be engaging with So I think all of you probably have your own stories, yes, and maybe not, of the importance of public health. So awesome. So we can continue on because we're going to run out of time fairly soon, I feel. So as many of you know, public health accreditation is a measure of the health department performance against a set of national recognized practice focus and evidence-based standards. And I'm not like promoting anything. I am just saying that we started this process now probably about 7 years ago. And if Lenny's on here, she'd be like, "No, it was this day." But that's my accreditation officer. She keeps me on my toes. And so on the next page, so these are the 7 steps, and right now we're in the accreditation decision part. We did have our site visit. We're working on some documents, but this is just laying the foundation of why I'm going to be moving into the next steps. And so I just want to make sure everybody knows. Next one, next slide. And so we applied under the 1.5. So we had to comply with all of these 12 domains. And they have changed, but we still have to comply with these for right now. So next slide. So what we did 5 years ago, and we're just starting the process again, was really looking at our strategic plan. So we've hired a facilitator, actually with the Public Health Foundation, our favorite person, and she's helping us look at our work group. We set together 2 days, actually next month. And then, but looking back at our former one, we didn't let that just sit on the shelf. So like I said, my accreditation coordinator is very on the ball, and she makes sure we review that semi-annually. And it's really a living document. And but we're using that one as the foundation for our next programming. So next. This is leading up to. to other things, but I'm laying the foundation here. So community health assessment, and I'm sure most of you are all familiar with that, but we are just finishing up our second one, and we're very excited to finally get this done. We've been working on it for a little bit. And so we use the Indian Community Health Profile process, and there's MAP and, a few other ones that others can use, but we really identified with this because it was really similar to what we thought was important for our community and how they utilized and went around in a circle kind of thing. And, we're circular people. And so we've seen many things. So sometimes we had a lack of local data in some areas. We used primary and secondary communication or data. We also had some lack of communication sometimes. And so we really tried to look at that and change it for this time around. And so we utilized the Great Plains Epidemiology Center to analyze our data. And so looking at what is needed now. And so we've reviewed the document, and then pretty soon, I hope pretty soon, we're going to be presenting those findings to our board of directors, our public health directors, the community. We did already a little bit, and then just having it available. So as a tribal health department, we do not have to publish it, like have a link on our website as some of the other health departments do, because it is tribal data and we are a sovereign nation. And so we're able to just have it available for people if they wish. And so data sovereignty is very important to me. And so we really try to respect that because some of our numbers are very, very small. And so as a small community, you could probably identify who those people are. And so we want to make sure that we do things in a very respectful, culturally centered practice. And so that's very important to me. So next. So some of our successes of our CHA process was establishing our committee to help support the programs. The data collection allowed for integration of data and being able to identify other data sources that could be sought out. And the committee was able to review the data, identify some strengths and opportunities for change. And there are so many great things happening within our community, and we were able to draw strength in order to implement these programs. And looking back, I don't have it in front of me, but we can see the changes from 5 years ago to today, especially in those specific community health improvement areas that we really focused on. And so that just shows how important our work is and how proud we all should be in that. So next. So this is getting to the good stuff. So Tribal Community Health Improvement Plan. So we selected a facilitator. We selected some priority areas, and then we dropped them down from 5 to 2. And now we have today starting on our access to care, which is always important, and then health promotions and education. And so we'll be forming 2 separate work groups. We're finishing up that work right now, selecting data points, outcome objectives, and work plan. So next. So I want to tell one of our stories, and this is really the woman in the middle, Camilla. She is my YEP Nagu director. And so this is really her putting her stuff together, and it was one of our Tribal Community Health Improvement Plan priorities. And so you can see how we took that data and we made it actionable steps. So, so next slide. So for the previous 5 years, we had a healthy living work group. And so our TCHIP goal by 2025 was to reduce the obesity among adults from 68% to 64.6%. And so as you can see, Winnebago obesity rate exceeded both the state and national rates. And so this is from our previous CHA or Community Health Improvement Plan. And so you can see Winnebago is in the blue, and Nebraska's in that greenish, and then national is black. And so clearly we're a little bit more round than other areas. Next. But we had a lot of community strengths. So as I described earlier, we have the Ho Chun Ko program. That's our diabetes prevention program. And so they utilize that to think about how we move to the future in focusing on that number that we just seen. So they had members of the Winnebago community were referred by the 12 Clans Unity Hospital that were older than 18 with pre-diabetes or at risk for diabetes. And their goal was really to reduce their body weight by 5 to 7%. They did this over a 12-month period. The classroom lessons followed the CDC's prevention T2 curriculum. And what they found out from that is really we needed more of a high intensity weight management program. Next. So High Siwi Nagu was launched in February of 2022. And so this targeted our Winnebago community members that were, again, referred by 12 Clans Unity Hospital that were 18 and above, had an A1C less than 6.5 and a BMI greater than 30. And so the goal now, again, was to reduce the body weight by 10 to 15%. And their time frame was a little bit shorter than that classroom one of 9 months now. But they really looked at 4 pillars of this program. And as you can see, these are the pillars. So they're following the Obesity Medicine Association comprehensive care model. And so we have healthful nutrition. So we have a dietitian, physical activity. So remember our wellness program, behavioral health, our behavioral modification. So remember our behavioral health program, and then medical management. So we also have our YEP Nagu nurse practitioner. And so we looked at all of those pillars to be able to implement this program. So next. So I just talked about the 4 pillars. And so they looked at the weight loss drug that was approved in 2021, but they didn't want to solely rely on willpower, lifestyle, and just this meds, right? So that's why they really developed and looked at those 4 pillars. So the participants take a pre and post screening in February and November. And then they do assessments. So, this is just like a research, right? We took A1Cs, blood pressures, weight, BMIs, body comps, exercise minutes, and all kinds of assessments. Continue. And so after the 9 months for the first cohort, which we had 10 participants that graduated, they lost a cumulative of a total of 392 pounds. So about 39.2 pounds per person. They also reduced an average of their total body weight by 16%. They reduced their systolic blood pressure by 12 points, diastolic by 7 points. They improved their QOL by 0.83. And so you can see that those pillars, but people had to be invested because you had to do all of these things almost every single week. And so it was very intensive. But doing all these things really helped make that change. So, think of each person, and 4 pounds a month is an average for the person. Is really a healthy way to lose weight. It's not like we're losing, tons of weight all in 1 month, and so we wanted to make sure that these were sustainable outcomes. Next. So this is why we really looked at, so again, looking back at our data and the weight management options that we had. So our low intensity, we partnered with our Northeast Nebraska. They had a weight management program that they targeted members of Thurston County, which is where we live in, to reduce their weight by 5%. And they would just be like texting using the Noom, N-O-O-M, and utilizing that kind of application there. So very low intensity for people. And then we gave other people the opportunity for moderate intensity, where we have the Ho Chunk Hope, where people would reduce their body weight by 5 to 7, so just a little bit more, right? And then they had the classrooms under looking at the T2 curriculum. And then we have the more high intensity with the Hayasowi Pinagu program that really is looking at that 9-month with all of those 4 pillars. So really trying to give all these weight management options, knowing that how our obesity rate. So using the data to inform change, right? So next. So by 2025, reducing obesity rate among adults from 68 to 64%, roughly. And so we achieved that. So we went from 68, 2021, we had 57, 2022, we had 63%, and then in 2023, we had 59%. So, but this is, all of these options, and then of course increasing our Whirling Thunder wellness, really giving more adult education and opportunities for people. And so this work doesn't end, we continue. And so we still have these because we still want to continue to reduce this area, even though it might not be our specific priority area. You don't want to lose the good things that you're doing too. So next. So do all of you have a performance management plan? Yes, no, maybe. All right, it looks like probably yes, some no, and it might be out there somewhere. All right, so we'll talk a little bit about the R's. So next page. So what does performance management look like for us? So back in 2016, I really wanted to start this public health accreditation journey. And so I hired my accreditation coordinator in 2017 because I knew that I couldn't do it with all the other things that I have to do. And that I didn't want it to be a part of somebody else's plate, right? I wanted to really do it well. And I wanted to make sure that that individual really was able to work on it. And so, so we've been actively working on our accreditation, but it was really even more than that. So it was just developing and implementing this performance management system was a part of it. So we'll talk more. So next one. So in 2020, we implemented our performance management system. We drafted a QI or quality improvement performance management plan. We finished a full year and learned all kinds of things from the process. I met with all of the health directors along with my accreditation coordinator, and each of those programs that we went and talked about earlier select 2 PM monitors. That's a lot. I mean, when you think about 18 programs, but they still do them and they report on them every quarter. Again, we worked with the Public Health Foundation with Sonia. We love her. And we scheduled multiple PM trainings for the staff. We reviewed draft plans to finalize them. And we have learned so much from the first time we did it to today. And so we really learned our proper PM process and really how to merge PM and QI stuff to really adequate meet needs. So next. And so in the initial years when we consulted with our Public Health Foundation, we really wanted to train and coach our staff through these measures. One of the things we did was we had them do PM coaching with all of the health directors. We also did that with the staff as well. And so we developed a couple of forms to assist us in this. And annually, I send them out to remind them of the line of sight. And so we send out the strategic plan goals. Of course, these are going to change here soon, and our priorities. And then they have to basically figure out what their PM would look like and how do we tie it back to one of these areas. Next. So I pick on accreditation, and this is a little bit old, but so her line of sight, to give you an idea, by September 30th, she wanted to develop and introduce the QI PM training for the committee to participate in. She wanted to strengthen the workforce development efforts so that the staff can lead improvement improvement for work, and then to maintain an efficient organization that meets the health needs and demands of the community. So see how it builds on. So we have a clear line of sight of what we want to do and how do we, what is it tied back to? Next. We also wanted to make sure that the health directors were just not coming up with these all by themselves. So we wanted to really make sure that they were engaging with their staff. And so we developed this form. So it was sent out to the health directors before our quarterly health directors PM measurement meetings to discuss them. And so we wanted to make sure that the staff were engaged in selecting the monitors and that they were also engaged throughout the year. And so we monitor them on a quarterly basis. And so they're just red, green, and yellow, or red, yellow, green. And so they report them on the monthly reports. And now we have started with a software program so that they can put them right into VMSG. I don't know that acronym, what that means, but they can put it in there and then it creates the tracking tool for them. And so it's very easy. But on the next page, or the next slide, you can see our very first one was an Excel document. So if you don't have no money, that's okay, and you just need to do Excel, this is basically what we did. And so I would just keep track of them with the help of Lene. And, quarter one, I never expect us many people to be in the green, and we always have those high achievers, but and then some not, but that's okay, because basically by the end of the year, we want everything really to go from red to green. But if they don't, then that's the next quality improvement stuff, and we'll talk about that here now. So, do you have a quality improvement plan? Okay, awesome. So, looks like the majority of you do, and others maybe and maybe not. So, all right, well, we'll talk about ours. So, our quality improvement principles for ours was we wanted to make sure that was really tribal member focused, wellness orientated, employee engagement. It had leadership involvement. It was data informed practices. We use quality improvement tools, and we seen prevention over correction. So we wanted to make sure that our processes were achieving the excellent outcomes rather than just fixing the processes after the fact. Like, we wanted to continue to evolve, right? And continuous improvement. So basically, we can always do better, right? That's what I think. Always, always. So next. So the model for improvement, as many of you probably already know, the ACT, Plan, Study, Do. And so, or Plan, Do, Study, Act. I always get it all backwards, but Lene keeps me on my toes, so she reminds me what to do. And so we utilize this in our quality improvement. And so we wanted to have the foundation, right? And so we plan what we'll do, and then we carry out the tests, we collect the data, then we do the quality improvement project team, implements the test, collects that data on the change, documents it, then we study it again in order to use the results to lead to improvement, and then we act and we adopt the solution. And so, next one. So really our 6 leaders, 6 foundational elements for our QI culture. And so these were the questions that we wanted to be asked, I guess, or wanted asked. So the leadership. So how well does the health department's leadership set the direction for the performance improvement, allowing for necessary steps, systems, processes to support QI, and communicating to the staff with transparency? We wanted to make sure we had teamwork and collaboration. So does the health department encourage internal, external collaboration, utilizing best practices, sharing lessons learned, and breaking down existing silos? Employee empowerment. We wanted to make sure our staff provided with the necessary training, the resources for use in quality improvement methods, and actively engaging in problem solving in the improvement. And community focus. Does our programs and services incorporate the community voices in the agency's decision making and continuously strive to exceed expectations? And then do we have a formal structure to manage quality initiatives and centralized system for measuring performance and addressing gaps? And then to what extent does our program improve specific processes and systems and yield programs and services of the highest quality using QI methods? So we developed a committee. Next page. So our membership includes, of course, myself, or if I can't be there, which is highly unusual, somebody else. Of course, my accreditation coordinator. We have a public health nursing representative, our YEP NAGU representative, medical services, optometry, and then others as deemed necessary by the committee. So depending on what the quality improvement project that we have, that's when we invite other experts in that field. Next. So we developed a team charter. Sorry, it's really small, so you might not all be able to see it, but it has like the team name, the subject, the problem, who is sponsoring it, the team leader, who are the members of the QI initiative here, who is our primary customers, do we have what are the needs addressed, we want to develop SMART goals, some considerations, what resources, key stakeholders, and so it kind of just guides them on what we need to consider it, I can't even say it, consideration as we're doing the quality improvement. Next. So we made sure to outline in our quality improvement plan all the staff roles and responsibilities, all the way from the board of directors, myself, the accreditation coordinator, all of our health directors, our staff, and then the QI committee, as well as the project team. Next. So our QI project prioritization and selection process, we identify possible QI projects from any of our health department programs. We have nominations for who would like to lead the project. We develop SMART goals. We prioritize and select projects. They're data-driven. Program evaluation. We look at the impact, the urgency, and of course the buy-in of the staff, which is always so important. But first, they look at the next one, which is they fill out this form, which is a quality improvement project nomination form. And people are just beating down our doors to give us these. No, I'm just kidding. They aren't, but I wish they did. Someday they will. But we're getting there. We're getting more as we go along. So anyone in the whole department can put in this nomination form, whether they are in that program or not. So if I work for Whirling Thunder and I see something that's kind of lacking or I think could be improved in behavioral health, they could put that in and say, hey, I think this is an area for improvement. This is what I think. Can we get this baseline data? And then they go through and fill this out, and then the committee reviews it. Next. And so we keep this QI project status tool going, so we know what projects we've done in the past, what the statement was, the measure of progress, and the storyboard that was completed at the end. And I'll show you that here shortly. So the next, we developed a QI process chart. And so it helps people, I think, always when we have some kind of chart to show like who does what and where. And so you can see the health department staff identify it's a potential QI project. Then they complete that nomination form. Then they give it to anybody on the committee. The committee reviews it. Then they approve it or talk amongst themselves. And if it's approved, then they form a subcommittee to start working on that, including the director of whatever program that is targeted. And then at the completion, we do a storyboard, and you can see an example of one of those. Next. So we always do one administrative and then one programmatic. And so our customer satisfaction survey project was one of our administration ones. And so at first we didn't get very many at all. And so what we did was thinking outside the box. We went through the Plan Do Study Act. And so we started doing QR codes with our satisfaction survey. We got it out to the people. We used it during COVID. Every time someone came through to get their vaccination, we actually had the satisfaction survey and we handed it to them with the time that they could leave. So being creative, handing it out with the t-shirts, handing it out wherever we could, and we jumped in rates. And so that was one of our success stories. And then the next one on the next page was our workplace wellness project. So again, the Plan Do Study Act. And so we were not getting a lot of workplace wellness people participating. So what we decided to do was we put it as a QI project. How could we get it to the people? And so basically what this committee decided to do was we took it to them. So our fitness staff actually started going to the work sites and doing small activities that you could do within that particular location. Whether that was chair yoga, they could do small things within a small, we don't have huge areas, I suppose, in office spaces, but they made things happen for them. And so it was really exciting. And they still do that today as well. So next. So our expected outcome, it was really our hope that we would improve our performance and provide quality services that lead our community to be healthier. And then next. So this is not really part of, our whole what we needed to accomplish today, but I'm really proud of our communications plan. And so to me, this kind of is in line with some of the other things. And even our logo in the very beginning, we had didn't have this logo when we first started about 6 years ago. And so this was also very meaningful to our staff. They developed this. So we had votes and everything. And so I just want to talk about that a little bit, is that so we even were renamed about 6 years ago, and now we're the Winnebago Public Health Department. And that was based on the staff. That's what they wanted. And then we chose our chief Whirling Thunder, which made sure in the Winnebago Treaty that there was a doctor provided in that treaty. And so we recognize him being in the middle. And then the star, as you see, is 12 points, and that's the 12 clans for the Winnebago tribe. And then we have our green and blue, and that represents our earth and sky clans. And then around is our Ho-Chunk applique, which is significant to the tribe as well. And so you won't see this logo, I think, anywhere. And so we're very proud of that. And so we make sure we have that on, all of our stuff. But we had to develop a communications plan. And that was like, if you think about it, it's another QI thing. We've been constantly evolving and recognizing where we do not have our strengths and really moving our objects and education forward. Next. So our workforce development plan. So we didn't have anything like this like 6 years ago. And so that's why all of this is it's so exciting to talk about, because we have come so far in the last 6 to 7 years. And so I'm so proud of my staff. And of course, none of this work can be done without all of them, all of everything that they bring to our health department every day. And so we did training with the health directors. We conducted a survey with our staff, like age, race, professional degree, retention. We conduct training with the staff. We decided to do incorporating the competencies. And so we enhanced through our orientation. We have annual and individual training plans. We added to job descriptions. Now our training plans really help with a lot of that educational that I was just talking about a little bit ago, like increasing that if they want to go back to school to do things, finding a way to put that in their training plan and help supporting them along the way. And then of course, implementation. Next. So the most important things that we have done through our workforce development was we have created trainee positions really in order to grow our own. Some of our positions is really hard to find and find people. And so we've turned them into trainee positions. We've modified some of our programs and activities to really intertwine some of the cultural beliefs. We've incorporated whole chunk language classes, understanding our family dynamics with our kinship. We have tons of beading, sewing activities. Every day, one of our staff members goes and smudges, which so he prays and he has a sage going throughout our entire area. We make sure that we are supportive of our funeral and wake practices and our attendance and any of those things. And so in the training plans, we really encourage our staff, whether they are Indigenous or not, Winnebago or not, to encourage them to seek out our whole chunk language and historical classes, and increasing our staff education and advancement. We work with summer youth, high school kids incorporating into our programs. We work with apprenticeship, God, some of these words, for our college level into our programs as well. And so I really believe in students. And so we take them as many as we can, as long as we can. Next. We are excited because we have just been awarded Indian Health Service Public Health Infrastructure Grant. So that is really looking at our access to care and helping to support that work group as well. We are looking at our workforce development with some new Horizon training. We're looking at our strategic plan, continuing training for our performance management and QI processes. And then we're very excited that we will be doing our very own behavioral health risk factor surveillance system. And so that data will be ours. And so like I talked about earlier about data sovereignty and how important that is, that we have good data to be able to make those decisions as we move forward. Next. So some of our accreditation activities, so we had weekly domain meetings. We still have them every so often because we're finishing some of our documents. But we've learned so much through this whole process. We have staff meetings, all staff meetings with the health department. We send out emails all the time. Health directors meet every month. We have a group chat that we talk to one another. We have a share drive with all of the policies and procedures on it, all the job descriptions, our accreditation plan, the branding toolkit, all the brochures for all of those departments that I talked about. And so that any staff member can go in there and look at somebody else's, just so that they know what's going on. Next. So some of the successes that we've had in those past 5 years, we created a mobile community crisis response that I talked about, the weight management program. We've also increased our partnerships with our sister, the 12 Clans Unity Hospital. We've implemented several plans and processes as the result of our accreditation planning. We have our Wojakina Waka Risisiski home visitation program, I get them confused now that I'm going on a roll, but our revitalization of kinship support around maternal child health. And we've also increased in our behavioral health and recovery services, some trainee positions. Next. Some other notable is that we've increased staff education. We've increased our infectious disease education with a partnership with our Little Priest Tribal College. We've increased activities at the senior center. We're doing climate resiliency planning. We have really data-driven initiatives, and our grant response has also changed. So we're no longer just grabbing grants wherever we can. We really make them focus based on like our quality improvement, our performance management, and our tribal community health improvement plan. Next. So some of the lessons learned, I think that we continue to look at the data and interpret what it's saying to us. Sometimes there's a lack of data collection among other entities within the tribe. So we really work with as many entities as possible. And we always include our staff along the way. So all of those committees that we talked about, we don't just have health directors, we have middle staff, frontline staff, and so that we have everyone that we possibly can providing input on those discussions. Next. And as a tribal entity, we are really representative of our people. And so we believe in our resiliency, which is found in our culture, our prayers, our sacred places in nature, and our ceremonies. And really, that's why we're still here and we embrace our work and who we are today. So last slide, it just says Pinagigi. So thank you. And if you have any questions, there's my contact information and you can always reach out to me directly. I do get back to everyone eventually. Thank you so much for sharing some time with me.
Wonderful. Thank you so much, Mona. This was such a great presentation. So now is the time that we will open up the floor for questions from you all. We have about 10 minutes. So please go ahead and put your questions in the chat box. I know, Ron, you've been hanging out in the chat for a while.
There is a question.
Great, go ahead.
To get us started, and then if it slows down, I have a question for Mona.
Okay.
So the question is your human resources department based in the health department, your hospital, somewhere else in the tribe, and do they assist with your workforce development efforts?
So our umbrella is the Winnebago Comprehensive Healthcare System. And so they provide all the shared services. So they have our HR, the IT, and other areas. And so they do support both sides of the house. So, and I know there's a few more houses, but those are the big houses, is the health department and the hospital. And so they provide support to both of us. I think, so WCHS is, remember, only 6 years old. And so they are still, I think, learning. They have been more supportive recently and more engaging, but I think sometimes if anyone else is a part of a healthcare system, sometimes the hospital takes a lot of air and the health department, we're strong all by ourselves, right? So we'll still get the job done.
There's a question about the work, the weight inclusivity work in conjunction with weight control. Always interested in knowing about both. Do you deal with all areas of weight control?
Yeah, so so I don't have Camilla with me, but she's our YEP NAGU director. And so those were her slides. So I stole them from her or borrowed them. They're all ours. So I think what we did was really the response. So that's why we developed that 4 pillars. And so I think they're just always looking at the data to inform what we can do. And so our sister, the 12 Clans Unity Hospital, is now formulating their own weight management program that might be a little bit less intense than our 4 pillars. And so that would be another option for our community members to participate. So, but if you want more information, you can always email me and I can hook you up with Camilla to talk more stuff.
So Mona, something that you mentioned to me a while back as you were pursuing your doctorate, working full-time, pursuing your doctorate, that there were different reasons for doing it, but one of the reasons that you share had to do with your staff, and maybe you could talk a little bit about that.
So, yeah, but you're gonna make me cry, Ron.
Oh, I'm sorry.
Because I love my staff. And so, we all have different challenges, right? Being community members, parents, working full time, doing all of those things. And so, I wanted to show the staff that they could do it too, if I could do it. So I am full time, obviously. It was COVID when I started back in 2020. So that was an interesting dynamic, as we can all be sure, right? Because who knew that public health would be so famous back in 2020 when we
Really.
first started out, right? But anyway, so there was a lot of challenges, but I think how I believe everything is always meant to be the way that's supposed to be. So I'm supposed to be in there, but really was to show my staff that if I can do it, they can do it too. So if I can work full time and I can, be somewhat of a mom some days, and I can be an EMT during COVID as well, then they can find a way, and all of our ways are different. So it might take them a little bit longer, but as long as that's what they want to do, then I try to support them in however I can, whether that's just encouragement through texts or just listening if they stop in. Because I have a staff of 115 or so, but I also try to present that to the directors too, is that, family first is really important to me, and it should be to our staff. And so I try to remind them of that as we connect every few months in person now. So it's very exciting.
Yeah. So Mona, I must say there was a comment with several additional hearts with it that your whole presentation has been cry-worthy. So you've offered some wonderful information for all of our participants. And here's a specific one about some assistance or guidance you might be able to provide some of our colleagues, state colleagues in particular. The question is, our state has their first federally recognized tribe. What are best practices in terms of collaborating in a culturally responsible way with a sovereign tribe? It's a new relationship. Any words of wisdom that you would wish to share?
I think it's always important. At least for us, we're very relationship built.
Oh no.
Well, we know sometimes the connections are not great.
If you want something done today, it's not going to get done today, but but you build on those relationships and you continue showing up, and however that is, like we don't always have the greatest state relationship either with Nebraska, but they try to include us in different things, and we do try to also show up to the table. And that's what I always tell our health directors as well, is that even though it might not, we might not understand quite where our place is in that discussion, is that as long as we show up to the table, they can't make decisions without us if we're not there. So if we're there, at least we can be part of the discussion. And so I think that's important. Even if one tribe doesn't show up anytime, I would still continue to try to connect to them and try to reach out and invite them. Go and ask, to stop by and visit and just start building relationships, because I think those are just so important to us.
And Mona, if I may add, very first time I worked with a tribal nation, I was given advice, and that was to listen, to be humble, and to be genuine. And I know one of the things I did during the session, we were doing a training, and I referred to members of the tribe as registered members of the tribe. And during a break, one of the elders came up to me and put his arm around me and just said, Ron, just as a piece of information, we're not registered, we're enrolled members of the tribe, and there's a difference in the way that one presents it. And the fact that I up front said, I'm not a member of the tribe, I'm not Indian, and I may misspeak here or there, and I really would appreciate you letting me know. And an elder coming up to me and giving me that information was very compelling and important. So I think it is important to be, again, humble and to be listening. And Mayella, you're looking at me like, Ron, be quiet.
No. We have time, I think, for maybe one more question, or if Mona, you have any closing remarks that you want to leave us with. We have, about a minute.
So I think my bandwidth, I must be time to go because my bandwidth is getting smaller, it looks like. So they must be like taking me off the network.
Well, somebody put in the chat, Mona, that you're a genuine leader, that the world needs more genuine leaders like you. And you've given people much to think about and to take home. And that was the intent. I'm not going to make you cry again.
Well, thank you so much. I appreciate this opportunity. I always love talking about my staff and all of the good work that they're doing and that we continue to do, and hoping that others can learn from us and, you know, inspire them to do, you know, good things in their own ways, right? And so that's what we all want to do is be the best that we can. So thank you.
Thank you.
Oh, thank you so much. And thank you everyone that participated in this session. We really appreciate your engagement with the polls and in the chat box and all of your questions. So thank you all very much. We would love for you to join our next session. Now what? Tools to use moving from workforce assessment to strategic decision making, which will begin at 3 p.m. Eastern. Just a quick reminder, you will need to log back into the Train Learning Network conference page to access the Zoom link for the next session. The links will be available 30 minutes before each session. Thank you all so much and see you shortly. Mona, I think you're on